All right, refresh. What are some anterior circulatory pathway stroke symptoms?
Bilateral weakness,
Sorry?
bilateral weakness. Anterior,
Anterior,
bilateral.
not bilateral.
One side, unilateral.
Unilateral,
That's what I meant.
Always unilateral, so always just one side of the body. Has to be, left arm, left leg. It can't be right arm, left leg. That's not two sides of the body. So as soon as two sides of the body are affected, it's posterior circulatory pathway. So it's vertebral arteries, basilar artery. It's anterior circulatory pathway, it's ICA, and also the vessels that are fed by the ICA or branches of the ICA. So those blockages could be in the brain, like middle cerebral artery, anterior cerebral artery. So just keep that in mind as well when we start getting into Circle Willis. So that's all anterior circulatory pathway. So what else is anterior? So unilateral symptoms of like plagia or paresthesia or paralysis. So, weakness, paralysis, numbness, tingling, not just on one side of the body.
Aphasia, speech, aphasia.
So anterior, difficulty speaking, yeah. Dysphasia, and
Aphasia.
yeah, with the S. Aphasia, so unable to speak or gargled speak. The one with the visions with affecting one eye, so that temporary blindness or shading in one eye. Remember the name of that one? It starts with an A. Sounds pretty. Amaurosis fugax. So amaurosis fugax is a temporary transient. So sometimes they say transient because it's temporary. Your vision either goes and then comes back, or goes and comes back. So temporary transient blindness or shading in one eye. And with that, it's the same side that's affected. So all those body symptoms, it's the contralateral side of the brain that's affected. So, if it's left side of my body that's affected, it's the right ICA. If it's the right side of my body that's affected, it's the left ICA, or the left side of the brain that's the issue. So posterior circulatory pathways, vertebral basilar disease. Now we talk about when the symptoms are bilateral, both sides of the body, have weakness, anything that affects your balance and coordination. So that's ataxia, when you have uncoordinated muscle movements, vertigo, the sensation that the room's spinning around you, diplopia, which is double vision, drop attacks. So that's when you actually, go down, but you don't lose consciousness. I think what are some of the other big ones? Dysphagia. That's difficulty swallowing with the G, dysphagia. And then we had some non-localizing ones, so things like syncope, headache, like auditory disruption, like you're hearing sounds, or confusion, some of those things like that, altered mental status. All right. So in terms of common causes of ischemic stroke, so we said there were two different types of stroke. There was hemorrhagic stroke, which is the brain bleed. So you think of like an aneurysm rupturing in the brain, and you're bleeding out of the brain, or you've had some sort of traumatic brain injury where the brain's bleeding out. That would be a hemorrhagic stroke. Or we can have ischemic stroke, which is much more common, and that's due to blockages of the vessels, causing diminished perfusion to the brain, leading to damage of the tissue in those vascular beds. The primary causes, of ischemic stroke, we have atherosclerosis, build up of those atherosclerotic plaques. We had briefly mentioned, again, the most common location for atherosclerotic buildup is going to be in the carotid arteries at the bulb and the bifurcations. You can also wind up with embolus from the heart. So patients who have coronary artery disease and they've had a heart attack, their heart's weak, clots can actually form within the chambers of the heart, so particularly in the left ventricle. We worry about thrombus developing in the left ventricle, then getting injected from the heart, and then finding its way into the carotid system. I can block the blood flow. We'll talk a little bit, about these each in more detail. With patients who have hypertension, can wind up with hypertensive arterial sclerosis. So that hypertension damages and hardens the arteries. You have dissection, which could limit the blood flow. So when we get Again, separation of that intimal and medial layers, we wind up with the dissection, so it narrows the channel which blood flow can pass. Then there's vasospasm we're going to talk about, and pre-thrombotic states, patients who are in these hypercoagulable states. So atherosclerosis. So again, about up to 50% of cerebral infarcts are associated with embolic debris and thrombi originating from atherosclerotic plaques at the carotid bifurcations. So those atherosclerotic plaques can start to become unstable. They can hemorrhage and they can break apart, and little pieces of those plaque and then will now start embolizing, and they'll travel up, the carotid arteries, work their way into the brain, and then they'll block the smaller arteries within the brain, causing ischemic strokes. So atherosclerosis is the most common form of arteriosclerosis. Arteriosclerosis is kind of that umbrella term that refers to the thickening and hardening of the arteries, the loss of elasticity of that arterial wall. And then atherosclerosis refers to that depositing of those cholesterol, fatty lipids within the vessel wall. Like we said, atherosclerosis commonly occurs at the carotid bifurcations, so in the bulb, and the distal vertebral arteries. It can also occur at the origins of the vessels as well. So those are common locations as well. So the proximal, distal, basilar arteries form the aortic arch, the origins of the vessels there. Atherosclerosis can lead to stenosis, potential thrombosis in the vessel. Then those little atherosclerotic plaques can break down and embolize. And if it becomes significant enough, the vessel can actually become occluded. So again, as those atherosclerotic plaques start to develop and build, progressive gets worse and worse until the point where we wind up with a dynamically significant lesion, which limits the blood flow getting through that vessel. And then eventually over time, that vessel can become occluded. Like we said, little pieces of those atherosclerotic plaques can break off, travel, embolize, wind up in maybe the ophthalmic artery, or they can wind up in the middle cerebral artery, anterior cerebral artery, wherever the pathway might go. So again, we look in the bulbs, we look in the bifurcations of the vessels for those development of those atherosclerotic plaques. We're gonna have a whole lecture looking at these different atherosclerotic plaques, trying to determine which ones are more stable, which ones are more unstable and more susceptible to potential, rupture and emboli. Because again, not all plaques are created equal when we're looking at cerebral vasculature. Some additional sources of emboli. So additional sources of blood clots could come from valvular vegetations. So these are patients that have an infection on their heart valves. These vegetations, so this isn't necessarily blood clot. So those vegetations, that bacterial growth, kind of think of it almost like it's like cauliflower or broccoli growing on a valve. And it's an infectious colony of this bacteria growing on the valve. And little pieces of that cauliflower, broccoli, we call them vegetations in echo, can actually break off and embolize and travel to the brain into cardiac thrombi. So that's actually blood clots within the chambers. A myxoma is a cardiac tumor. So it's one of the most common cardiac tumors that we can see in the chambers of the heart. So pieces of that tumor can break off, embolize. When patients have rhythmic disturbances of the heart, so they have arrhythmias, particularly atrial fibrillation. This can cause ideal conditions for the development of embolus or conditions that develop thrombus within the chambers. If patients have stenotic valves, again, that also kind of limits the ability of blood flow to pass easily through the heart and create stasis of blood within the chambers of the heart. that could lead to the formation of thrombus and emboli. Patients who have prosthetic valves also. Um, Anyone with a prosthetic valve is going to be on some form of anticoagulation because those prosthetic valves create nice surfaces for clots to form upon, and also can create situations where thrombus can develop. Cardiomyopathies or certain cardiomyopathies, particularly dilated cardiomyopathy, where we might end up with stasis of blood in the chambers that can eventually turn into clots and potential emboli. Acute myocardial infarct, so patients are having a heart attack, then the heart's not beating properly, so that creates a nice situation conducive for thrombus formation. So bacterial endocarditis is valvular vegetation, so those two essentially are the same thing. And then physical trauma or damage to the inner layer of the heart endocardium or the valves. So hypertensive arteriolar sclerosis. So patients, when they have elevated blood pressures, this can contribute to heart disease, worsening of that atherosclerosis. So there's the elevated pressures injure small vessels, can injure the small vessels of the kidney and the brain. A change known as arteriolar sclerosis. As those vessels get damaged, the walls become thicker and thicker and thicker and can lead to occlusion of those small arterioles. This can lead to small localized areas of infarct. Dissection. So we know carotid dissections, dissections are just a separation of the intimal, that inner layer from the medial layer of the vessel wall, the arterial wall. When we're talking about the cerebrovascular system, they often occur in the distal to that carotid bifurcation. So they're usually limited to the area just below the base of the skull. Dissection could lead to stenosis, potentially lead to occlusion. That wall is also, or that vessel now is weakened. So we can potentially wind up with a pseudoaneurysm developing off that vessel as well. So they can bulge and become aneurysmal and lead to development of pseudoaneurysm. So with, again, that carotid dissection, we get the separation to a true lumen and a false lumen. So in this case, they're both, appearing red, flowing in the same direction, but one of these represents a true lumen, one of them represents a false lumen. So we need to Doppler and try to figure out which one is which. Again, the false lumen will have a very, funky looking Doppler pattern, whereas the true lumen will have a more typical arterial presentation. Pre-thrombotic states. So again, there are certain patients with abnormalities in how the blood coagulates that causes them to be more predisposed to developing thrombosis. So this would be a significant cause of stroke in younger people. So, if you have when you get a board question, that talks about a young person having a stroke, you would have to think of things like, factor V Leiden or sickle cell anemia, some sort of coagulable disorder that would lead to them, potentially having a stroke. Because again, typically atherosclerosis isn't something that we see in young patients. So since arteries, have a thicker muscular component to the vessel, they can undergo vasospasm more readily than a vein can. So this is primarily, again, something that affects, just the arteries, vasospasm. So since it's a muscle, like think of like, when your muscle spasms, it tenses up. So that's basically what's happening here is we're having a spasm of the muscular portion of that vessel where it actually constricts the vessel and creates narrowing of the actual lumen. So, that could be so significant that it actually, can completely even occlude it. So you can wind up with such an intense vasospasm where, almost nothing's getting through or it's completely occluded. Um, so basically that's what that's saying here is, it's a narrowing of the lumen of one or more intracranial arteries due to constriction of that arterial smooth muscle layer. And it causes morphologic changes to the blood vessel wall. Large blood vessels near the base of the skull are primarily affected and reduce blood flow. So this can result in hypoxic ischemic brain injury. With vasospasm of the intracranial arteries after subarachnoid hemorrhage is a significant cause of stroke. So when we get into transcranial Doppler, one of the things that happens when patients have had traumatic brain injury, they've been in an accident, their brain's bleeding internally. One of the things that they're very susceptible to developing is vasospasm. So they are on continuous monitoring with transcranial Doppler to look at the velocities in the vessels within the brain, particularly the middle cerebral artery, to kind of get ahead of the curve so they can kind of see this vasospasm as it's forming, as it's processing or forming and progressing, as that artery is getting more and more narrow. So they're looking and assessing the middle cerebral arteries in particular, but they look at middle cerebral, anterior cerebral. They do these transcranial Doppler exams to kind of monitor the velocities of the blood flow, because as it's becoming more and more spastic and that narrowing keeps increasing, the velocities keep going up and up and up. So we're going to learn that the doctors will do procedures where they adjust the patient's CO2 levels within the bloodstream to cause the vessels to actually dilate to kind of prevent that vasospasm from occurring or getting severe and eventually, leading to more hypoxic brain injury. So kind of associate vasospasm with brain bleeds, with subarachnoid hemorrhage. So they kind of go hand in hand. So anyone who has had a subarachnoid hemorrhage, brain bleed, brain trauma, they're very susceptible to developing vasospasms after that injury. And they have to be continually monitored for the development of vasospasm. And then that vasospasm could lead to hypoxic, ischemic brain injury if not treated or corrected. We're going to learn a little bit about, the treatment and the process later in the semester. All right. So our risk factors for carotid disease. Well, we're going back to our first vascular. When we're learning peripheral arterial disease, it's the same four, which is nice. Our hypertension, diabetes, smoking, and high cholesterol, hyperlipidemia. So again, all these are, correctable, controllable. So diabetes, causes atherosclerosis to form, particularly at a younger age. Smoking irritates the intimal lining, as well as causes vasoconstriction, and having high levels of cholesterol in the blood is associated with the atherosclerotic development. Additional risk factors: patients who have heart disease, particularly, patients who have arrhythmia. Atrial fibrillation is one of the arrhythmias. They have an increased risk of stroke. Patients with other valvular disease like mitral valve prolapse may be the cause of stroke in younger patients. And then there's additional risk factors that have to do with gender and race, obesity, age, familial history. Look at other previous medical history. Even vitamin B deficiency has been tied to increased likelihood of stroke. The two most common causes of ischemic stroke or brain ischemia are going to be hypoperfusion, so underperfusion, not enough blood flow getting there, and then embolization, so pieces of either atherosclerotic plaque or thrombi embolizing and blocking the vessel. So with hypoperfusion, not enough blood flow, it could be stenosis, high-grade stenosis in the carotids, vessel becoming occluded because of that high-grade stenosis, as well as embolus or thrombus, and then embolization of that vessel. Additional causes could be aneurysm, dissection, and separating the intimal layer, causing a narrower of the channel. We're going to go a little bit into some non-atherosclerotic lesions, and then talk about carotid body tumor and its subclavian Steele syndrome. So with hypoperfusion, with stenosis, again, atherosclerotic plaque, is a common pathological condition. So the arteries become thickened, they're hardened, they lose their elasticity. There's buildup of those fatty plaques within the vessel, creates the narrowing. And then this in turn limits perfusion of blood flow into the brain. So it's important when we're doing carotid Doppler to really differentiate between stenosis and occlusion. It's particularly important when we get into treatments because it really dictates what the doctors can do. If the vessel is just stenotic, there are more surgical interventions or much more interventions that are on the table versus when the vessel is completely occluded and there's no blood flow getting through. So in terms of arterial occlusion, we can make that diagnosis by demonstrating the absence of arterial pulsations. We can see echogenic material filling the lumen of that vessel. We have to demonstrate absence of flow, both on color and spectral Doppler. So we're going to put our power Doppler on. We're going to do our pulse wave Doppler settings, minimize our settings, or optimize our settings. I don't want to say minimize, but we're going to lower the scale, lower the PRF, make sure there's no evidence of things like trickle flow in the vessel, that it truly is completely occluded. When the vessels do become occluded, after a while they become much smaller in size, so they start to become atretic. So sometimes they can even be very difficult to see. Patients who've had long-standing, occlusion of these vessels. Um, get into the Doppler. We'll do this. So I'm gonna give you guys the numbers that we need to know. Make yourself a little chart. These are gonna be the carotid velocities that you have to memorize now. Because there are specific numbers and velocities that we look at to determine the degree of stenosis. Um, Problem with these numbers is they've changed, but Boards hasn't caught up. So you're gonna go to hospitals and you're gonna see Christiana and you're gonna see the vascular lab and you go to Riddle and the numbers and the chart's gonna be different, but when we look at the vessel, we're looking and the numbers are a diameter reduction. That's important that we recognize that this is diameter reduction that we're talking about. So it's a normal vessel, a diameter reduction of 1 to 49%, 50 to 69%, and then greater than 70%. So once we get to 50%, 50 to 69, that's considered now hemodynamically significant. Everything less than that, I hate to say it, the doctors don't care, but they care, but it's not to the degree of become considered hemodynamically significant. The parameters that we look for to determine this, we look at peak systolic velocity, so PSV. We look at end diastolic velocity. And then we look at this ICA ratio. So it's ICA. Sorry. CCA ratio. So those are the numbers that we look at. So when we say a carotid vessel is normal, you can only ever say it's normal if you don't see any plaque at all. So the moment you see a little bit, even the teeniest speck of plaque, you can't say that that vessel's normal. It automatically falls into that 1 to 49%. Even though it's such a broad range, you still have to say, less than 50% or 1 to 49, however, they report it out. Stinks. I've had patients that have the little teeniest spot of plaque, and then they get the report less than 50%, and they start bugging out, not realizing that it's just the teeniest little speck of nothing, So normal again is absolutely no atherosclerotic plaque within the vessel. Peak systolic velocities are going to be less than 125 centimeters per second. And diastolic velocity is less than 40 centimeters per second. And then the ratio is going to be less than 2. Less than 2. So that 1 to 49, since it's not hemodynamically significant, it's not affecting the velocities at this point. So everything is the same still. Less than 125. Less than 40 centimeters per second. Less than 2. So that's easy. So now we get into 50 to 69% stenosis. With these velocities now, since it's hemodynamically significant, the velocities now are starting to go up. So our peak systolic velocity now has a range of 125 to 230 centimeters per second. And diastolic velocity is 40 to 100. And then that ratio now, we compare the ICA velocity and divide it, bless you, by the distal CCA, is 2 to 4. Greater than 70% now. It's just greater than 230, greater than 100, and greater than 4. And this is 7 meters per second.
What do you mean by the ICU ratio? What is that?
Trying to find a good picture where I can, well, we'll just use this one. So we take a ratio. When we have a stenotic lesion, what we Doppler, this is in our ICA here. We use that ratio in instances where patients might have a weak heart. So like I would take the velocity that I have here in the ICA and divide it by the velocity I get in my distal CCA. And we compare those two numbers to see how much that velocity is accelerating going from here, through that stenosis. So like, for instance, if like a patient, I'm gonna throw some numbers in here, like this was 100, but this was only 20 centimeters per second because they had a very weak heart, wasn't pumping strong, a very elderly patient, or they had some sort of heart disease or whatever. And the blood flow was 20 centimeters per second, but then accelerated all the way to 100 through here. Even though 100 doesn't, meet our criteria in terms of like these velocities and these numbers, that ratio is telling a different story. It's saying that blood flow accelerated so significantly. It was a 5-time increase, through that stenotic lesion. And that ratio, kind of supersedes those velocity numbers. I mean, your eyes would tell you, you're looking at it like that looks really narrow in a blockage. And you put your pulse rate Doppler to like 130 or 200, that there's no way that's only 200, Then you go back, you look at that ratio. The machine's gonna actually prompt you when you get in lab there, particularly the Phillips. When you finish your ICA, it's gonna have you pick your highest ICA velocity to then divide that by your distal CCA to see what that ratio is. So this is called the ICA systolic ratio. They look at the peak systolic velocity to see how much it's increased through that stenosis, just compare it to the proximal portion. Then you compare distal CCA to whatever your highest velocity is in your ICA. Typically, again, most stenotic lesions are going to be there, so it's usually the proximal, ICA that has the highest velocities, but that's what we're going to be doing to get that ratio. This would be, now we start looking at, patients that have disease. This patient had bilateral carotid artery stenosis. We have our carotid vessel, we see an area of focal narrowing of that blood flow. Atherosclerotic plaque, within the vessel wall, we can visualize on both sides. And then as we Doppler, we're going to practice trying to Doppler through these areas of stenosis taking multiple sample measurements as we walk through that stenotic lesion, looking for our fastest velocities. So when you do a carotid ultrasound, you don't ever just take one ICA velocity. You're always kind of just minimizing your sample gain, slowly taking multiple pulse waves through that stenotic lesion, fishing around and looking for that fastest, velocities through that stenotic lesion. If you only take one velocity measurement, doctors are going to be pissed at you. They're gonna be like, all right, um, you know, so you always want to look for those fastest velocities. Because again, things might be on the cusp. You might be on that border between, 50 to 69 and greater than 70. And as you sample through, like, oh wow, all of a sudden it jumps up here to 300. I found, the really fastest velocities. Because again, we're only taking a single slice through that vessel. So this is just kind of one view. So by taking those multiple sample sites, we could kind of get a better understanding of the hemodynamics. So then comparing that ICA to that CCA velocity, they got 3.93. So both of these kind of fall into that 50 to 69%. The 165 for peak systolic velocity there falls into that 50 to 69. The ratio falls within that 50 to 69. Then on the left side, they got a more significant, velocity here. The ICA measuring 350 centimeters per second. And the ratio also being, over 4. So one thing when this flow becomes, or the blockage becomes super significant, and it's right before, becoming occluded, we can wind up with trickle flow in the ICA. So sometimes it's referred to as a string sign or trickle flow. When we put our power Doppler on, it looks like we don't see anything in there. We come a little further, we're picking up a little bit of flow, some little signs of flow within that. The reason I left this part blank is because this is near occlusion. Once we're near occlusion, flow could be variable. Like some patients, when they're really near occlusion, they can still have very fast velocities. Some people, their velocities just kind of drop down to almost nothing. They just get a little bit of trickle flow. So these are all variable now. So you can say variable. Kind of all going across. Again, it's very important to try and really look for any signs of flow in that ICA. Even the most minute bit of flow, so in this case, there's only 8 centimeters per second. So it's very, very slow. It's very dampened. So that's a, significant Targus waveform. In this case, they put their power Doppler again. They got a small little string of flow going through that vessel. So the reason this is so important now, if there is still a little bit of flow able to get through, the doctors are going to be able to get a small catheter in there. They could potentially try and, do a balloon angioplasty, open that up. If they have to do an atherectomy, and try and, break up that plaque and remove it, they can do that. Let's go back to share. So this was a very unique situation that can occur. In this patient, their common carotid artery is the one that's actually occluded. So there might have been maybe a large thrombus that was ejected from the heart that wound up in the patient's carotid artery that's lodged in there. But now blood flow is no longer coming up that common carotid artery, but it didn't quite make it to the bifurcation. So this is, again, this is most likely it is going to be something that happened acutely. Clot got ejected or thrombus got ejected from the heart, is now lodged in their CCA. since it happens so rapidly, you know, the brain's going, oh my God, I need to get blood flow into the ICA somehow. And in this case now, the ECA now is the one that's actually supplying blood flow. We have retrograde flow in the ECA coming back down and then working its way now up the ICA. So this is also a good example too, to like look at your colors. So flow direction now, you have to be very good at looking at flow direction, looking at your color box, looking at your color map, and figuring out which direction blood flow is going. You know, is it antegrade or is it retrograde? Because things are going to start reversing and flipping on us because the brain is doing whatever it can to get blood flow up to its territories. So in cases of ICA occlusion, we can have retrograde flow in the ECA to bring blood flow up to the ICA. So body's going, all right, my face doesn't need it. You know, the muscles of the face, the brain's way more important. I have a source here. We're going to steal some of that blood flow from the ECA. We know that ECA has additional anastomosis and branches with some of those other vessels. And we're going to direct it now into the ICA. Again, look at your color map. So again, blue is showing away. So if you draw a line down, blood flow going away, that's going up to the brain. Blood flow in the ECA is headed towards us, even though it's red, it's retrograde. So in this patient now, we have our common carotid artery splitting into our bifurcation. We also have to be careful when we're looking at vessels that are occluded. With ICA occlusion now, we have to also make sure that this truly is the ICA and not the ECA that's occluded. And it can be, again, a little bit tricky because the ECA now might have similar appearance to that ICA, because this is the only vessel now that blood flow is getting through. And we said that we have those pre-Wasilian connections. So branches of the ECA connect with the ophthalmic artery in the brain to get blood flow into the brain. So now, since that ECA with those branch connections with the ophthalmic, blood flow is going to the brain, this now will change resistance and will appear similar to the ICA in its Doppler appearance. So this is where, again, things start now to become tricky when we have these processes going on. So in this case, you know, no flow is demonstrated in that ICA. ECA is showing a stenotic lesion, so we get filling or narrowing of the intimal layer. There's still a stenotic lesion now in the ECA, and I'm sure that the Doppler characteristics of that ECA now have changed. We're going to learn that this is referred to as internalization of the ECA, or internalization of the external carotid artery. So it's a mouthful. It's being internalized. It's taking the characteristics of the internal carotid artery, or the ICA. Again, why? Because this has branch connections with the ophthalmic, and it's going to be bringing blood flow into the brain via that ophthalmic artery. So it's going to have lower resistance. So thrombosis, another cause of hypoperfusion. This is the formation or presence of thrombus within the vessel. So clotting within a vessel, which may cause infarction of the tissue supplied by that vessel. So thrombosis could be secondary to stenosis or an embolism. So we can have an embolism get lodged, or embolus get lodged in the vessel and cause that vessel to further thrombose. High-grade stenosis, again, could lead to the development thrombosis of that vessel. The term embolization, which refers to, again, a foreign substance or a piece of thrombus that moves through the circulatory system until it lodges into a distant blood vessel, causing that embolism by completely or partially obstructing the vessel. So in terms of the arterial system, The most likely source of emboli is going to be from the heart. And then another source are those atherosclerotic plaques that break down, the unstable atherosclerotic plaques that can break down and embolize. Aneurysms. So aneurysm is abnormal localized dilatation of the blood vessels. So it could be due to congenital defects in the vessel themselves or a weakness in the vessel wall. So things that weaken the vessel wall, atherosclerotic plaque buildup, hypertensive patients can have weakening of the walls, congenital defects. People have connective tissue disorders like Ehlers-Danlos or Marfan syndrome. So with aneurysms, they rarely occur in the cervical carotid artery, so we rarely ever see aneurysmal carotid arteries like within the neck. So if they do become aneurysmal, it's usually intracranial. So this was just demonstrating that patient who had a CCA aneurysm. See the vessel coming down, becoming large and aneurysmal in that segment. Because it's so aneurysmal, it had impacts on the amount of blood flow now in that vessel, so the velocities were impacted. To correct that aneurysm, they placed a stent to correct it. With the stent placement, you can see the obvious stent in there, the epigenetic lines, the double epigenetic lines where the stent has been placed. And we had to return back to a normal looking Doppler appearance, the Doppler signal for the vessel. Carotid dissection. So again, dissections can occur between the intimal and medial layers. Could also occur within the medial and between the medial adventitial layers, but typically it's between the inner and middle layers, where we get a separation of those arterial walls, creating a true lumen and a false lumen. Some etiology or some causes of carotid dissection, and it could be congenital defect, fibromuscular dysplasia or FMD. Anyone remember the patient population for FMD or another name, or we refer to FMD as string of pearls or string of beads. So this is a medical condition that primarily affects females. You see it more in younger females. It affects renal arteries, can also affect the distal internal carotid arteries where we get that string of beads or string of pearl appearance of the vessels. That can lead to weakening of the vessel wall. Physical trauma or can lead to also dissection of the vessels. Sudden neck manipulation, underlying weakness of the muscular layer of the wall that allows for that intimal tear. Even excessive coughing or sneezing with respiratory infection can lead to potential dissection. So with that true and false lumen, then the false lumen may be blind ending, so it may come to a blind end. If it does that, it creates a natural pocket, that could wind up becoming thrombosed, where the blood flow becomes clotted. As it becomes clotted, it will bulge and expand, and causing that true lumen to become more and more stenotic. Sometimes the false lumen can reconnect with that true lumen. With dissection, patients are usually either asymptomatic or they may present with hemispheric Symptoms. So symptoms affecting one side of the body. There might be cranial nerve palsy, headache, facial or neck pain. So that dissection can cause stenosis, can cause occlusion of the vessel. Pseudoaneurysm uh, can form. Dissections are usually treated with antithrombotic, antihypertensive medications, and then they eventually have to do surgery to correct it. Carotid dissections usually originate off the aortic arch and they extend superiorly into the CCAs and into the bifurcations and ICM branches. Cervical carotid artery dissection may undergo dissection spontaneously. So with these, they may originate in the ICA or involve the CCA and causes dissection. High blood pressure, weakening the vessel walls, fibromuscular dysplasia, nonviolent trauma, rapid neck motions, and then some of our connective tissue disorders like Ehlers-Danlos and Marfan syndrome. With the condition cystic medial necrosis, we get weakening and breakdown of that medial layer. Again, leads to weakening of the vessel and that separation. Or maybe due to direct trauma, so direct injury to the vessels. So with dissection, best way to see them is going to be our transverse view. When we're looking at the vessel in transverse, we see that intimal flap coming across the vessel like that. That membrane moves freely within the arterial lumen, so with the pulse, we can see it moving up and down. You can see how it shifted during the cardiac cycle. And another transverse vessel view. See that intimal flap coming across the vessel. We open up its sagittal, we can extend that intimal flap as it runs through the vessel there. And then it's sagittal, we can see our two channels of blood flow now. One representing the true lumen, one representing the false lumen here. So you can see the true lumen has a a fairly normal looking arterial signal, whereas the false lumen, this is get the complete reversal there. So it's a funky looking, it's an abnormal Doppler tracing. So you can really tell the difference between your true and false lumens. So with that bidirectional flow in that false lumen. There are times again when we can actually demonstrate two different colors, one in the true lumen and the false lumen. So this is probably a closed end dissection where blood flow is going in, hitting the end of that dissection, and then reversing back out. So we can demonstrate that also on that Doppler signal, showing that reversal of flow in the false lumen. So again, that true lumen has that continuous forward flow, false lumen showing that reversal. In this case, the false lumen has become completely thrombosed and clotted, and it's now pushing on that true lumen, causing it to become highly stenotic. So they're measuring velocities in that CC of over 400 centimeters per second. So again, that's blood flow that's really moving fast, highly stenotic. Another separation showing two different colors, the true lumen and the false lumen. So in terms of classification, you can utilize the Stanford classification method, which breaks dissections into either a type A or a type B. It's really easy. Type B is just descending thoracic aorta, so there's no involvement of the ascending or the arch. So type B dissections are not gonna affect the carotid arteries because it's already distal to where they branched off the aorta. Whereas type A can affect the ascending, the arch, as well as the descending, or it could just be the ascending and the arch, and then these could, potentially uh, impact the carotid arteries. So type A are the only ones that are going to be impacting the carotid arteries. So spontaneous dissections, these often will occur distal to the bifurcations, often involving the distal ICAs at the entrance of the skull. They're usually spontaneous or following some sort of trauma. So really the places that we're looking at are going to either be the proximal CCA coming off the aortic arch or the distal ICAs as they enter into the base of the skull. Again, we're looking for that intimal flap visualized on ultrasound. Yeah, much easier to try and appreciate that over a transverse to see it coming across the vessel. Look for flow disturbances, within the true lumen and the false lumen. Try and visualize, again, that duplicated lumen. With dissections, we want to document the origin, where it begins, how far it extends. Look at the characteristics of the flow in both the true and the false lumens. Determine the patency of both ECA and ICA. Those pseudoaneurysms. So carotid pseudoaneurysms are, exceedingly rare. Most often a result of some sort of violent trauma or percutaneous jugular vein catheterization, maybe during some sort of therapeutic or diagnostic arteriography. I've only ever seen personally one patient who had a pseudoaneurysm in their neck, and the doctors were their minds. It's like big, it was bulging and like pulsating on their neck, and they were like, they didn't have any idea what to do. So other causes of potential dissection are that the artery becomes weakened, the arterial wall becomes weakened, things like vasculitis and Ehlers-Danlos, Marfan syndrome, fibrous dysplasia. So it's different from FMD. FMD again primarily affects those medium to small vessels. With the pseudoaneurysm in the neck, they present with a palpable and possible pulsatile mass, neck pain, maybe cranial nerve palsy. So there's going to be a spherical mass-like lesion with blood is seen entering into the neck that circulates with the carotid artery. So like any other pseudoaneurysm, it has that to and fro flow pattern seen in the neck of the pseudoaneurysm. With this, the consequence is rupture, and this would be life-threatening. Treatment is surgery or potential non-surgical wall stent. A lot of this again depends on the size, location of that pseudoaneurysm. Looking at that presence of the to and fro flow pattern of the neck, the length and diameter, the patient's neck. Are there any portions that are thrombosed? You can see in transverse carotid artery, the neck of the pseudoaneurysm, then the pseudoaneurysm itself. This being, partially thrombosed, so this area is thrombosed, still actively bleeding in that area. So carotid arteriovenous fistula now. These are almost always a result of either trauma, either violent or iatrogenic, as accident, maybe blood trauma or penetrating trauma, an attempt to jugular vein catheterization. Again, they went to the vein, punctured into the artery now, and that created a fistula between the artery and the vein. They might present with visible neck mass, discoloration, so ecchymosis is kind of like a purplish discoloration, so like a bruising. It might be palpable, might feel a palpable hematoma, an audible thrill or palpable thrill, or audible bruit, so an palpable thrill. The veins are going to become very distended and dilated because now you have all that arterial blood flow entering right into the venous system. So hyperdynamic venous drainage. So treatment, is surgical. They have to ligate and close this connection. Then there's going to be turbulent, violent blood flow, a palpable thrill, a color bruit. So some non-atherosclerosis lesions now. So there are arteritis. We've mentioned before a couple of different types of arteritis that patients could be impacted. So there was Takayasu's arteritis. That was a form of arteritis that affects primarily young Asian women. Takayasu's arteritis affects larger vessels. So this one would potentially affect the aortic arch, the common carotid arteries. So with that arteritis, we wind up very similar to what a vasospasm looks like. We get thickening and inflammation of the artery walls. That thickening of the artery walls will lead to narrowing of the vessel lumen, creating stenotic lesions. So arteritis causes stenosis. Patients can also have temporal artery arteritis. So that's superficial temporal artery. So temporal arteritis was also referred to as giant cell arteritis. That was one of the ones that we had mentioned. So temporal artery arteritis or giant cell arteritis. If we're imaging the temporal arteries, we would have this hypoechoic halo appearance to it. See the thickened walls, and then with that temporal artery arteritis or the giant cell arteritis, they have to do a biopsy of the actual vessel to make that diagnosis. FMD, fibromuscular dysplasia. Again, this is abnormal fibrous muscular tissue development of collagen vascular connective tissue disorder. So again, this one's idiopathic. So with FMD, we refer to it as the string of pearl or string of beads appearance of the vessel. Commonly affects the renal arteries, but can also impact the axillary, iliac, basilar, carotid arteries, the hepatic arteries, as well as some of the intracranial arteries. So when we see this with patients, we're typically looking at the internal carotid arteries, more mid and distal, so any above the bifurcation. So we can kind of use that to, make that differentiation or the diagnosis between FMD versus Takayasu's arteritis. Takayasu's we're going to see in the proximal CCA, closer to the arch. FMD we're going to see more distally, so mid and distal ICAs, intracranial, further along, further downstream. And both of those, affect younger women. This is more prevalent in the Asian population, but again, both of them are affecting, younger to middle-aged women. When we get to abdominal vascular, we go over into FMD. It also, causes patients to become hypertensive because of its impact on the renal arteries, on the stenosis in the renal arteries. So most often, patients do have FMD, have hypertension, have uncontrolled hypertension, high blood pressure. And again, that high blood pressure also damages now the carotid vessels as well. So with carotid involvement, we worry about transient cerebral ischemia. There could be, we worry about also hemorrhagic stroke, again, weakening of the vessels, leads to them becoming aneurysmal or potential rupture, as well as, becoming stenotic. So with FFD, there could be an ischemic component to it. There could also be a hemorrhagic component to it that we worry about. Yeah, where we see FMD is gonna be, relatively distal in the ICAs. So it usually presents at a younger age than atherosclerosis would. So when we see stenotic lesions in the absence of calcified clot, we can use this kind of as suggestive of FMD, particularly when we're talking about, again, distal segments. So atherosclerosis, we see at the bulge and bifurcations. If we start getting, stenotic lesions, elevated velocities in those distal ICAs, it's a young female patient, we kind of have to make that association and assume FMD. Yeah, and FMD can present different, for each patient. So again, we can have that classic kind of string of pearls, string of beads. Again, we're looking, mid distal ICA, so further away from that bifurcation. Another presentation where we just get a severe narrowing there and then a reopening. This was just an angiogram showing a woman or a patient with fibromuscular dysplasia. Figures this is the obvious one where you get the dilatation narrowing, a string of pearls, string of beads. So carotid body tumors. So a normal carotid body tumor is a tiny ovoid structure located in the adventitia of the carotid bifurcations. It sits between the external and internal carotid arteries. The carotid body tumor has a very low malignant potential. So it is a benign tumor. It's a component of the automatic nervous system there's a component of the automatic nervous system that participates in the control of arterial acidity and blood gases. This carotid body tumor is a highly vascular structure. It's usually fed by branches of the external carotid artery. Most common presentation of a patient who has a carotid body tumor is a palpable neck mass with headache. These carotid body tumors are often seen bilaterally. So the standard therapy treatment for someone who has a carotid body tumor is surgical excision of that tumor. So you might see questions that talk about the bifurcation taking a claw-like appearance, think like a lobster claw. When you have a bifurcation that looks like that, you're going to wind up with this, heterogeneous, like kind of hypoechoic mass sitting right in between that bifurcation. So right at the bifurcation of between external and internal carotid arteries, you see this large mass that forces the vessels to become separated like that, taking this claw-like appearance. There's going to be vascularity to it, blood flow within it. So in this case, you could see the obvious feeding branch coming off the external carotid artery. Do we know this is ECA? Because we got little branches coming off there. We can easily identify that as our ECA. board questions I've seen, they like to show that nice crab appearance on it. Have you recognized that this is a carotid body tumor? I've seen them get sneaky in recent years and try and do a transverse view of this large mass sitting between ECA and ICA. So they'll do your vessels and transverse. You know, so you'll have ICA, ECA, like your mass kind of sitting in between there. It's got some flow in it. So even if they give you a grayscale picture, you know, it'd be like that. ECA, ECA, ECA. If they're nice, you know, they'll put color on there and so you can see that there's vascularity within it. Blood flow. Again, so we're just looking for this kind of like this hypoechoic heterogeneous mass that's vascular, sitting in between the carotid bifurcation. So, you know, they could trick you, try and do it in transverse. And they want you to recognize that that's a carotid body tumor. Or they like to give you that nice crab view, a crab picture like that, showing a carotid body tumor. And again, this can cause, you know, stenotic lesions. As this grows, it can compress the vessels, create stenosis. And then that has to be surgically removed. So that's carotid body tumor. Little guy. The carotid body tumor fed by branches, fed by the external carotid artery, sit right in between the carotid bifurcation. Right. Clavin Steele syndrome. We're going to take a deeper dive into subclavian Steele syndrome, but I'm just going to kind of introduce it a little bit right now. So this is a condition where blood, which is destined for the brain, is shunted away or stolen from the cerebral circulation because the patient's subclavian or innominate artery has either a high-grade stenosis or an occlusion that's proximal to or before where the subclavian vessels branch off. So subclavian Steele syndrome, the only way, stop share real quick. The only way for us to ever get subclavian, so what's going on now is we either have a high-grade stenosis, so it has to be very significant, or an occlusion of the innominate, or you know, in that proximal subclavian artery here, before where the vertebral artery comes off, and blood flow is not getting out to the patient's arms, or it's, you know, very diminished going out to the patient's arms. The body's actually going to steal some blood flow and bring it back down the vertebral to get it out towards, you know, towards the vessel or towards the arms or the extremities. On the left side, it can only be in this small area, you know, in that proximal subclavian right before where the vertebral comes off. And the same thing now. blood flow is gonna be stolen from the vertebral to go out towards the arm. If I come back down, we're gonna wind up with some retrograde flow in the vertebrals. When we start looking at subclavian steel a little deeper, we're gonna say, is it partial steel? Is it a complete steel? How significant is it? Usually it's, just one side that's affected, thankfully. But with this subclavian steel syndrome, like I said, patients are usually asymptomatic. They don't realize it, that this is going on. But we can kind of make that differential diagnosis by doing a blood pressure on the patient. So the side or the arm that has the lower blood pressure is the side where that lesion is, where the stenotic lesion is, and where the steel is going on. So those of you that have been in the vascular lab, that's why when they do a carotid ultrasound, they take blood pressures for both arms to see if there's any discrepancy between the pressures in both arms. So I know this says, 15 to 20 millimeters of mercury. For boards, it's, difference greater than 20. So when we're doing our PBRSLP and we're doing brachial pressures, I always had you make sure if the difference was greater than 20, go back and recheck. Yes, it should be closer than that. I should really honestly be within 10, but anything greater than 20 millimeters of mercury is a good indication that there is likely subclavian steel going on in this patient. So the pulses in the affected arm are going to be decreased. They're going to have weak pulses, weak pressures. Again, it's only due to occlusion or stenosis proximal to or before where that vertebral comes off. So again, if that blockage now, is further out, the blockage is here, subclavian steel is never going to happen. There's no reason for that blood flow to come back down because it's not going to go anywhere. So you're not going to have subclavian steel syndrome when the occlusion is distal. It's only in that proximal side. When we get into a little further with the right side, we said it can be in the innominate, in this area. That'll also impact our CCA. It'll have impacts on that CCA waveform and what it's going to look like as well. We'll have some issues there as well. So, and we can use that to kind of make that diagnosis of where it could potentially be. This is kind of just a schematic showing, what's going on. So here we have that occlusion in the proximal left subclavian. Getting no blood flow now, getting through there, coming up the right vertebral, up into the basilar artery, and then some of that blood flow does continue on into the brain, but some of it then is diverted back down the vertebral and then out the arm. So I saw a couple board questions, like trying to be tricky and sneaky, like patient has a left-sided subclavian steel syndrome. Where is the blood in, the left subclavian artery coming from? So it's coming from the right vertebral. Where that blood in the left arm is actually coming from. So the source of the blood flow in the patient's subclavian artery is from the right vertebral. Yeah, for opposite, yeah. So if the blockage is now on this side, source would be from the left vertebral and then back down the right side. Yeah.
I have a question.
Yeah.
You said that the difference is greater than 20 milligrams of mercury. Do you want
Millimeters.
millimeters?
Yeah.
Do you want us to remember the 15 to 20 or just keep it at 20?
Keep it at 20. That's what Force does, 20. Yeah. So with subclavian steel syndrome, the flow patterns can vary a little bit. You can have complete reversal. So this is where you have to just be careful that, you're not just Dopplering and you instinctively go, oh, I got invert. You hit invert. So you have to be careful with what you're doing. That look at it, like, oh wow, it's like you're doing your whole exam. Everything is in one direction. You go to vertebral and be like, oh no. Be careful you're not holding your transducer upside down. That could happen. But yeah, just don't be quick to invert. Be like, all right, wait a minute. Shift back to the carotid, particularly if you're on the left side, because with the left side, that's the only place we're gonna have the lesion. It's only gonna affect that. The left ICA is never gonna be impacted. So that's always gonna be antegrade flow no matter what, You can kind of fan back and forth and go, all right, that's red, that's blue, that's red, that's blue. So don't just invert. So again, steel could be complete, we got full reversal, yeah, partially reverse flow in that steel. So this is referred to as the crouching buddy sign or bunny sign. Excuse me. So like I was saying, if the anomated is the one that's impacted, we can also have effects now on the internal carotid artery on the right side as well. So flow could be completely retrograde. It could be targus parvis. Oh, dying. So that's one of the things that, excuse me, we're gonna look for when it's on the right side. If it's just vertebral that's impacted, we know that that lesion is in the proximal subclavian and not the innominate. So if you're a right ICA or the right carotid system looks fine, the right carotid, right ICA, all look normal. And it's just the right vertebral impacted, we know the location of that potential lesion. And we have to go and try and find it. This is another good, indicator too, that you don't just automatically hit invert. So they had an innominate artery occlusion. So this is a woman who had Takayasu's arteritis. So that Takayasu's arteritis caused such a significant, occlusion or narrowing of their innominate artery on the right side that the right ICA or right CCA was retrograde. They compared it to the jugular veins. Again, those should be opposite colors, but you got them both blue now. That's good. Another way to check yourself as well. And with the Doppler signals, everything was retrograde. You showed a retrograde ICA, retrograde ECA, retrograde CCA flow. So everything was flowing in the opposite direction. So physical examination, when you're doing a carotid ultrasound, we want to make sure that we, sorry, to share. When we're doing a carotid ultrasound, we want to make sure that, we ask our proper questions as to why they're here, why we're doing this exam. Did you experience any symptoms? What were your symptoms? To try and help us to, differentiate between potential anterior or posterior circulatory symptoms. Like, oh, I fainted. All right, do you remember fainting? Do you remember going down? Yeah, I remember it. I just dropped. I don't know what happened, So that's a drop attack versus actual syncope. Or, like, yeah, I was having, like numbness just on my right arm or my right leg, I just went limp and numb. Or I had difficulty speaking, slurring my speech, so we know which pathways are involved. That's going to help guide our ultrasound exam. Not so much necessarily for us, auscultation, but if they have significant stenotic lesions, the doctor might be listening. They hear the brewery with their stethoscope. We check blood pressures, so that's pulses. We can do bilateral, brachial pressures to see if there's any differences in the brachial artery pressures. Um. So carotid artery exams. Again, could be, are typically ordered for anyone who's had any sort of, stroke symptoms, TIA, so. Everything from altered mental status to slurred speech to, weakness on one side, vision disturbance, amaurosis fugax. They're also ordered, follow-up exams, so they've had interventional procedures that they've done, endarterectomy or stenting. They're also typically ordered before major cardiac surgery. So patients who are going for open heart surgery, they're going for coronary artery bypass surgery or valve surgery. They're potentially could be on, or they're going to be on, the heart and lung machines or anything on bypass. They want to make sure that they have good perfusion to the brain while they're under going for the cardiac surgeries, because they can make that surgery much more difficult. And they also could potentially stroke out during that surgery as well. So they want to avoid the patient having a stroke during the surgery. So if they have, also there's that correlation between coronary artery disease and cerebrovascular disease that, they might have significant blockages in the heart as well as significant blockages in the carotid arteries. So they might have to do both at the same time, attend to both, or, deal with the carotid before doing the heart or vice versa, see what's more critical in that point. So again, it's part of pre-cardiac clearance, getting a carotid ultrasound. Maybe there's some audible worry that this doctor hears. So getting into some interventions now. So just preventative interventions, you can control those controllable risk factors. Control your blood pressure, stop smoking, change your diet. So cholesterol, low fat foods, exercise. We could have medical treatments. So again, if you're diabetic, take your insulin, control your blood sugars, cholesterol medications, blood pressure medications. Patients could be on low dose aspirin, so antiplatelet medications to help thin the blood. Strep vasodilators to help expand the vessels. Or patients can be on anticoagulation medications, things like heparin, warfarin, Lovenox. We can administer if particularly a patient exhibits stroke signs. Doctors might give them TPA, which is that thrombolytic medications to actually break down and dissolve the clots that are associated with ischemic strokes. Or if medication's not enough, they might require surgical interventions now. So the two main ones are going to be endarterectomy and stents. Carotid bypass grafts are fairly uncommon. So endarterectomy. So this is now the surgical removal of atherosclerotic plaque. So this differs from an atherectomy, which we said was a non-surgical removal of that atherosclerotic plaque. This actually involves going up to the OR, actually cutting open your carotid artery, removing the atherosclerotic plaque. They oftentimes take a small portion of that intimal lining and the lumen to open it up to create a nice open carotid artery. During the procedure, shunt is used to divert carotid flow around the stenotic area to avoid neurologic deficit. So they're on a bypass machine to get that blood flow around the area that they're working on. So it's usually performed in patients that have a greater than 80% stenosis when they're asymptomatic or when the contralateral occlusion is present. The patients are very symptomatic. There being patients that have a greater than 70% stenosis, or patients that have had previous, TIAs or CVAs. They might necessarily get to that point if they had previous strokes. But yeah, typically endarterectomy, we're talking high grade stenoses. So, 70, 80, 90% stenoses. So when you start seeing velocities and start looking at numbers, it's people that they're velocities, could be in the 300s, 400s, 500s, It's really high grade stenoses. Those are the candidates for endarterectomy. So with carotid endarterectomy, we do play a part in this. We go up to the ORs, we scrub in, because they have to do post endarterectomy images after they've removed that atherosclerotic plaque. So we know before that's done in our lab in our departments. We have the before images, but the doctor also has to obtain after images. So you have your little portable machine. You go up to the OR. You scrub in. They're gonna have sterile probe covers and everything like that. So you're kind of a little off to the side. Patients there on the table, like you're not in that sterile field. You're gonna hand usually like the surgical tech, and your transducer. They're gonna prepare, with a sterile probe cover. You're just operating the machine at that point. So they take the surgeon's gonna take your little. It's a hockey stick probe that they use. So the little hockey stick, and they put it right down on the patient's carotid, and you're gonna be capturing some images, showing nice open vessel, 2D, get your color. You're gonna take some velocity measurements, they're gonna Doppler it. You'll have your screen kind of turn towards the physician as they're scanning. You're just kind of gonna be like that, taking your pictures. And then when they got enough sufficient pictures, they take the probe off, they'll hand it to you, and you kind of clean it off, and you go back down. So it's not, I don't want to say it's nice, but it's interesting, that you're involved in that. One of the students said she was at Christiana and they took her up for an endarterectomy, and the surgeon actually let her touch the plaque, like that they removed. She's like, "Doctor, do you want to feel it?" So, yeah. And she said it was actually much harder than she thought it was. It was like this gnarly, hard, calcified plaque. Like it was. So, but yeah, we're involved with endarterectomies. I always tell the story. Dr. Hines was one doctor I used to go up for his endarterectomies, and like he put the probe down. I'm like, all right, looks good. I'm like, I'm trying. I didn't even take a picture yet, man. Like, just give me 1 second. He's like, oh, we're good, we're good, we're good. I'm like, Hines, you're killing me. Like, anyway, so endarterectomy, the surgical removal of plaque. When they do, sometimes they can put a patch over it as well to really open up the vessel. So there's just showing kind of the suture, the closures, and, but it's night and day. Like anyone who's status post endarterectomy, like the vessel is huge. It's open now. There's absolutely nothing in there anymore, and it's nice, a clear, open pathway. So that's carotid endarterectomy. Surgical removal after atherosclerotic plaque. They sometimes also take the intimal portion of the intimal lining as well. When they close it up, sometimes they can also place a patch as well to have it nice, really nice and open. Intimal hyperplasia. This is a complication that we worry about after a patient has had an endarterectomy or some sort of intervention, but particularly an endarterectomy. Because we cut the vessel open, body's natural response to any sort of trauma is going to be inflammation and swelling. So no matter where it is, you cut yourself, it gets red, it gets swollen. Same thing happens now with the vessels. We wind up with this condition called intimal hyperplasia. You might also see it written as neo-intimal hyperplasia. So, now you're just being new, you know, don't want you to see like the word neo on there, be like, oh, I've never seen that before. That's new. So you might see it's intimal hyperplasia, neo-intimal hyperplasia. I see medial hyperplasia. Anyway, regardless, so basically this is inflammation and swelling of the vessel walls after an injury. So in this case, the injury was that carotid endarterectomy. So we can see this in bypass grafts, so not just in, you know, the carotid arteries, you can see these in bypass grafts, you know, in the extremities, the legs, kidneys, wherever they place stents or bypass grafts, or had vascular surgery or intervention, we worry about intimal hyperplasia. So there's, you know, intimal hyperplasia. So this was a patient's carotid artery, about 1 year, status post carotid endarterectomy. When we put our color on, you know, we can see now this hypoechoic area now, luminal narrowing, and the channel narrowing and more stenotic areas that blood flow is getting through. We know the patient's history. They had an endarterectomy, so they went in there, they cleaned out everything. You know, they gave this guy a new bill of health. Everything's been scraped out and cleaned. There's no reason for that patient now to have all of a sudden developed significant atherosclerotic plaque like that. You know, it took a lifetime for that patient to get there. 1 year, it's not going to become atherosclerotic again. They're not going to build up plaque that quickly. So you can use that little bit of knowledge that their status post endarterectomy, you know, like 3 months prior, 6 months prior. Again, this intimal hyperplasia doesn't happen instantaneous, so it's not like, you know, they go into endarterectomy 2 weeks later, you know, they have that significant narrowing. So it takes a little bit of time. So usually that time range is like months to a year or two and after. But usually that months to about a year range that we're looking at. So they'll go for their follow-up maybe 3 months later. They see now they're getting narrowing of that vessel, and it's going to be a result of intimal hyperplasia causing stenosis now. I mean, you have to have that reason why it's hyperplasia. So it has to be some sort of interventional procedure like a stent or a graft. Not, I would say stent, not really, because a stent's going to keep it open, but definitely like endarterectomy or graft are the main ones. So it's low level. It's going to be hypoechoic as well. So it's going to be more hypoechoic, whereas the community goes top by atherosclerotic plaques are more echogenic. So that's intimal hyperplasia. So another alternative to doing an endarterectomy would be placing a stent or carotid stent. So some complications include potentially a dissection as well as distal cerebral embolization. Evaluation of a patient with a carotid stent should include the plaque morphology, the vessel morphology, if they're very tortuous, as well as the location and extent of the disease. So there's a lot of factors that we have to look into, or the doctors have to look into to decide whether they want to go the stent route versus actually performing an endarterectomy. So again, if the vessel is very tortuous now and has a lot of twists and turns, that might not be ideal for a stent. If it's a very, large segment of disease, it might not be able to stent fully. So we can see, we have the narrowed carotid artery, again, right at that bifurcation there. They can go in, perform their balloon angioplasty, try and open up that vessel. And then on that catheter also has the stent attached, and they can then deploy the stent to keep that vessel open. Maybe they perform, again, an atherectomy with the machine that has that spinning blade on it with the vacuum suction, grind it up, suction into the tip of the catheter, and then deploy the stent. So this is just showing, like catheter tip. They designed one that's got a balloon portion that will expand to block the blood flow. So as they're, deploying that stent and they're, dealing with that atherosclerotic lesion there, no pieces of emboli or that plaque break off and embolize and cause stroke. This one's got a filter on it, to catch those atherosclerotic plaques, to prevent, embolus. Just showing examples of those, carotid stents. So in ultrasound, we're looking again with stents, the echogenic walls to indicate, where that stent is, so we know that that's not, our natural vessel wall. Just showing now the stent with that, power angio. You can really see now on ultrasound, where that stent ends. So they're Doppler, just before the stent, they'll Doppler through that stent, measuring their velocities. So there have been studies, looking at, stent versus endarterectomy, trying to figure out, what's the best. Then kind of just basis or summation of that, those trials is, there really isn't one better than the other. You have to really kind of look at, the age of the patients and the severity of the disease to try to figure out, which would be better, more beneficial. So typically, carotid endarterectomy is going to be more beneficial in an older patient versus placing just a stent. Great, so carotid bypass. So bypass or reconstructive procedures are used in cases when endarterectomy may not be appropriate. So in cases, where they have severe stenosis or occlusion near the origins of these vessels, if they have carotid aneurysm or recurrent stenosis with multiple repairs. Grafts may be synthetic, or they might be autogenous, meaning they came from the patient's body and have a venous origin. And a couple of different grafts that are present are carotid-subclavian, carotid-carotid, or an interpositional graft. We'll go over each. This was a carotid subclavian graft. So in this case, it can be used to restore flow to the subclavian and vertebral arteries. In cases, patients that have that proximal subclavian artery occlusion. So the vessel's completely occluded. They can't go in there to try and reopen that, recanalize it. They can put a graft in, steal a little blood flow from the patient's carotid artery to kind of reperfuse the vertebral and the subclavian now. So this is that carotid-subclavian graft, that first one, carotid-subclavian. So it's going from carotid to subclavian. Another picture here. Got again included an anomaly here, no blood flow was able to get through. They stent it, get a little blood flow from the ICA. I'm sorry, this is proximal subclavian. Sorry, proximal subclavian. So there's still a little bit from the proximal CCA, bring it into the subclavian to reperfuse it. So patient also has disease, at the origin of one of their carotid arteries. They can do a carotid, take blood flow from the good side, divert it over now to the side that's impacted or affected. Try and reperfuse those vessels. And interpositional graft. This is usually performed when a carotid aneurysm is present or when the CCA disease is so extensive that replacement or exclusion or excision is needed. So this is patients that either have a large aneurysmal carotid that they can't, repair, or their CCA is so diseased that we have to come up with something to replace the patient's CCA. So we're gonna put in a graft either using a vein or synthetic material to kind of replace the entire carotid system that's diseased in that proximal portion. And then they take that graft and they reattach it to the patient's ICA higher up. Trying a picture of it. So basically like an interpositional graft, what they would do is they just would take like a graft material, either synthetic, or use a piece of our vein and, connect it to where they have a good, viable arterial supply. And they'll just remove that whole section that's diseased and run it up and connect it to the ICA, somewhere up there. So it's basically just like, they're replacing the patient's CCA with either, a piece of your vein or a synthetic material, and just kind of getting rid of that whole segment that's severely diseased. So that's an interpositional graft, and they'll put it right in, like right next to the segment there. That's kind of what they're doing here. So this is that whole, that they've now replaced in that patient. They just kind of tied off, so that you can see them just there tied off. All right. Mhm. Lots to swallow.
Probably could just work down the whole like exploration then. Like for vascular too. I had so many things started. I'm gonna add it to my vascular too, Holy Bible. It's just, it's a bullshit.
So be able to label this picture.
That light, we've seen that before.
You've seen this one before.
Like we can directly just put on it.
We're gonna forget.
No, a picture, I have to say, so many. Yeah, but like that's the one we literally. Way back yonder.
Way back yonder.
That was about 5 years ago.
Does it? So,
The same, just like. Yeah.
circle the last picture, don't worry about the small individual segments. So just know, ICA, the middle cerebral artery, anterior cerebral arteries, anterior communicating artery, your posterior communicating arteries. So again, don't worry about P1, P2, just know posterior cerebral arteries, vertebral, basilar. So don't worry about the little individual segments, just know the main vessel.
Ready for that.
Ready for that one?
It's the only thing I'm ready for. I'm confident. I do.
I think that's flex.
I think we've like done that one. We've done that.
You've got the circle.
But you know, there's one thing it's to do. I can do one time and so we'll see.
I did have to review the wills a couple days ago.
You didn't have to stare at it for like 5 minutes. Good.
Okay. Remember left side, actual left side.
Okay. Terrible.
You know this one?
Not all of them, no. Mhm.
You're the one? Why do we need that one?
I don't know, it's PDF, I can't change it.
Cross it out with Sharpie
I know, start labeling other ones.
and then like add a different one.
I should, you're right, I should. When we're talking about ECA, we can utilize a couple of methods, to just differentiate, ECA from ICA. So what are they? What are some of the things that we can differentiate ECA from ICA?
Branches.
Branches, yeah. So what's the first branch of the ECA? That one you have to know. Superior thyroid artery. So superior thyroid artery is the first branch off the ECA. Last one is that superficial temporal artery, and we can use that as well, performing the temporal tap. So those are the two really the important ones, in terms of like ECA, to be able to ID it. But if we don't see any branches, what else?
The continuous flow and transverse, or that's ICA, so like flashing flow in
Okay.
ICA.
Yeah, so we can look at the Doppler characteristics. ECA is high resistant. So recognize your ECA waveform, recognize an ICA waveform.
Size of it.
Yep, so back to, so ICA has a lot of diastolic flow, low resistance. That gradual diastolic runoff, and then ECA much less diastolic flow. Got the deep dichrotic notch, sharp comes to a point. CCM. So CCA is actually a combination of the two. So, like if you had like, you know, three waveforms, ECA, ICA, and CCA, like look at, you know, which one, ICA is easy to tell, you can tell right away, ICA. EC and CCA might look a little more similar, but the CCA is gonna have more diastolic flow, so it's gonna be more resistant, have more diastolic flow than the ECA. And the CCA, typically that dichrotic notch isn't as deep as well. Let's see. How was the labeling? Let's see some of these. Now. Should give it to you now.
Sure.
I want it, like, it's pretty easy. Wait. For me? Um. I mean, I'm asking you guys, like, give me two, you know, anterior circulatory symptoms, two posterior circulatory symptoms. So again, know your symptoms, what's anterior, what's posterior. So give me some examples of each of those. What is the surgical removal of atherosclerotic plaque? What is that called? And arterectomy, just learned it. We discussed temporal tap, we discussed branches of the ECA. Discussed this. Symptoms, anterior, posterior. We know the branching of the vessels. Vertebral arteries come together to form what? Like, it's all kind of basic stuff. Vertebral arteries come together to form what? Ways to differentiate ECA from ICA. It's like recognizing the definition of intimal hyperplasia. So like I give you the definition of it. Recognize, like if you read the definition of it, you'll know what it is. Like I'm not asking you to write the definition of it. So what? I know.
Yeah. Run down.
Yeah.
Literally print this out and you guys fill this out. We're done.
Like demo to get five.
It's tough. Not easy, you know, it's
It's not easy, just.
I'd have a take home test.
it's 12 questions plus like 6 or 7 labeling, no, 10 labeling. It's good I broke it down.
I'm not worried about this.
No, don't worry about this one at all.
So it's on refresh.
Yeah. What's the first branch of the ECA? Superior thyroid artery. What's the first branch of the ECA? I hear mumbling, man. Superior thyroid artery. What's the first branch of the ICA?
Eyeball one.
The eyeball. The ophthalmic, yes, ophthalmic.
Not showing them that. Don't have the ECM.
Alright.
We did my house. What are you guys doing? I'm like, I'm small. What should we not have? Why is it really, we're gonna have like, maybe some of them did like a lot, and that's cool. You want me to know? For, yes, right. So, yes. Wait, do we need to know, this little sharp for the test?
Right.
Okay.
What's next?
That's
When is test three?
We got this.
Save. 13,
13.
I think, yeah, right before Thanksgiving break.
Okay. And that's like, everything's just a.
That's gonna be, you're like, looking at velocities and
Okay. So no.
looking at additional CRUD, when we actually get into looking at the waveforms. Cause now, once we start looking at waveforms, we have to determine is the disease proximal or distal to where we're sampling. So the
Okay.
waveforms are gonna be high resistance, or they're gonna be targus parvis. Oh, we get this stenotic lesion, how significant is it?
So we kind of know that's.
Yeah, we're starting to.
Nice.
When I realized. Yeah. That's what it is. Yeah.
And you know what? I'm gonna. We don't even. Like 49%. It's down here.
I feel like my brain organized. My brain wants to.
I'm resisting that help.
I don't need it.
Mine glitches.
Do you see my-
Mine took all over.
I start from.
And that's why I started doing the whiteboard method. It helps my brain work. If I'm like, okay, well, what do I know? Like, right, well, we're down and we right now. And so then I'm like, okay, well, I'm gonna do a different color pen to sit down, like what I did